Good afternoon. Oh, thank you. Green light. David has revealed my nefarious background as a payer. I would argue with his characterization that I'm a recovering payer, but more than I'm a relapsed academician. So my part of the talk is to talk a little bit about both the payer side of this and the provider education related to it. And given that I'd like to keep this more on a discussion level, what I'm going to do is to provide 4 questions and then 4 data points and get us back to being able to talk amongst ourselves. The questions, as you see up here, are who pays for obesity-related goods and services? Are the services effective and efficient? That's the payer side of me coming back out. Who can deliver the services? And then where do we concentrate our resources? So next slide. So you've seen this. Heidi Blank did a great job this morning of summarizing obesity care. I'm not going to go over this again, except to have you really get a visual image of this graph, with particularly where the red and the orange exist. And move to the next slide. This is where we have coverage. And this is an analysis compiled by the Stop Obesity Alliance back in 2014. It's Medicaid data. But what it shows is that there's virtually no coverage for drugs, as Carolyn noted. Only 5 states, 6 states out of 50 cover drugs for obesity, whereas we have near 100% coverage for bariatric surgery. And then when you go into the upper quadrants, you're looking at the various clinical services that can be there. And what's notable in that to me, and again, I haven't done an official correlation analysis, but the poorest coverage seems to be where the highest prevalence of obesity exists. Next slide. At the same time, we've got a tremendous demand, but our supply of folks who are really capable of dealing with obesity, as has been noted before, is pretty small. This comes out of a white paper done by the Bipartisan Policy Center, the American College of Sports Medicine, and the Alliance for a Healthier Generation, looking at saying that of physicians, only about a quarter of them feel like they know enough about nutrition to really be able to provide adequate care. And accordingly then, only 1/8 of the visits tend to come deal with nutrition and activity, and that fewer than 30% of medical schools really provide the type of care, education that should be provided. Now, that's kind of an issue in and of itself. The other issue is where we do have coverage. Let me see the next slide, please. Where we do have coverage, our payment systems really aren't helping us. So we've got the need. We've got certainly the obesity epidemic is alive and well. We've got variable coverage at best. We've got an undersupply. And then our payment system adds to that. So CMS only provides obesity coverage when it's provided in a primary care setting for typical E&M type coding. Now, we just saw that physicians are not really the best people to be providing that coverage. Now, a nutritionist or a dietitian can provide that coverage if a physician bills for it, but they're not allowed to bill for it independently. So we've got the best trained people who have the least ability to be paid for the services. So we've got a mismatch there that I think we can deal with. The other piece of this is to look about where we're spending our money. This is a representation of several models that really essentially say that only 10% of our health can be accounted for by health care. The rest of it really relates to behavioral patterns, social circumstances, and environmental exposures. We spend about 80 to 90% of our dollars on health care to get 10% of the impact, and I think we've got to change that. Next slide. So where do we go with that? I think the key for me is, and this is kind of the marketing version of David's slide earlier, It's really saying that we need to have an integrated approach that really focuses on getting the right care to the right people and probably spending a great deal more on social programs than we are on medical programs and healthcare right now. Thank you.